Just have a few colleagues joining. Is my screen visible to everyone?
Yes, sir.
Okay, that's fantastic. Manju, I'm going to make you co-host just in case anybody is waiting. So
Sure,
that,
sir. Sure.
okay, that's really kind.
Thank you, sir.
So today we are going to talk about periventricular leukomalacia, and this is an extremely important topic in that when you do cranial ultrasound over a period of time, screening programs that have been established for preterm babies tend to kind of focus on intraventricular hemorrhage because the risk of intraventricular hemorrhage is in the first 72 hours. 90% of cases present, and we spoke quite extensively about it. But the other reason for wanting to screen is because there's a proportion of preterm babies who have brain injury, which basically prevents much later. And this presentation basically can be quite significant with impact on neurodevelopmental outcomes later in the baby's life. Now, periventricular leukomalacia is what we know as preterm hypoxia ischemia, in that it's characterized by basically destruction, necrosis of the brain's white matter, and it actually reflects a softening of brain tissue. Now, this could either be because of pure hypoxia alone over a prolonged period of time, and the classic kind of description is term periventricular leukomalacia, which presents in cardiac babies, where they often don't have an element of ischemia, they have hypoxia over an extended period of time. Alternatively, you might have ischemia, which you commonly see in preterm babies who are hypocarbic, and those babies tend to have cranial vasoconstriction. And in particular, the arteries that are most at risk, would be the middle cerebral artery, and in particular, the deep lenticular striate vessels. So the periventricular areas of the brain in particular are affected in these situations. And really, once necrosis takes place, that necrosis basically heals over a period of time, which basically involves destruction of nerve cells, but there's also an inability of certain oligodendrocytes, which we call stromal cells or cells which basically are omnipotent, to be able to migrate into the right areas of the brain. And over a period of time, when we follow these babies up for neurodevelopmental problems, what we find is they present with motor problems. They can have problems with delayed cognition, which we know is part of, I would say, white matter injury that occurs alongside not just the periventricular areas, but diffuse white matter injury. So both of them can actually coexist. But in addition to that, one of the things that's really well described in the literature is these babies can have significant visual or hearing problems depending on whether the occipital, temporal, and frontal lobes are kind of involved. It's quite important from our perspective to be able to classify periventricular leukomalacia, not just by the grading, but also to be able to kind of understand that when it selectively involves certain areas, the prognosis changes. Now, we're not going to talk in very much detail about prognosis today. We'll be covering that towards the end, where again, we'll be talking about different articles, in particular ones that have been recently published by Natalie Mater, which basically talk about the severity of involvement of unilateral grade fours. But there is a lot of literature now being published on how diffuse and focal white matter injury or periventricular leukomalacia affecting different areas can actually present in severity. So to give you a feel of really what this is, so if you look at this, I mean, this is classically what you'd call a grade 4 IVH on the right side. So if I just annotate so that it makes it easy for you to see. So really, this is a grade 4 IVH that you can see on this particular side. But really, what you can see on the right side is this area of the ventricle. Now, naturally, it's also got blood inside it, but you've got this area of flare over here. Now, how this is going to develop and what's going to happen to it at this particular point, your guess is as good as mine. And that this could reflect an area of simple flare, or what we call is periventricular blush. Alternatively, it might, in with the right history, if you have hypoxia ischemia, go on to develop periventricular leukomalacia in due course. And really, what we've got to do is be able to understand which kind of flares we need to follow up, what are the differences, and we'll cover some of that today. Now, when we look at the areas of the brain that are involved, in particular, I would say that these paraventricular areas are very vulnerable. And the reason they're so vulnerable is because really, A, we see a lot of deep perforating vessels supplying them. So their blood supply, A, is quite compromised. But more importantly, from our perspective, really kind of omnipotent oligodendrocytes tend to migrate into these areas later on in life. And really, if you have early destruction, then the ability for this migration to take place is deeply hampered. And really, that is one of the other reasons why we often see necrosis presenting as cavitation in these areas later on in life. And both of these can really adversely impact neurodevelopmental outcome. Just going forwards, just going to stop my annotation. Now, one sec. So when we talk about the actual pathophysiology of periventricular leukomalacia, then really the worrying areas are the areas of watersheds, which basically occurs between the different cerebral vessels. Now, as I'll talk about in pathophysiology, there is a watershed zone between deep and superficial vessels. And really, that watershed zone is most vulnerable, which is why the periventricular areas become vulnerable. But really, you need to have a predisposing factor, something that's either causing a lack of blood supply. But what we also know is even in the absence of lack of blood supply, problems like infection, chorioamnionitis, antenatal infection that's been there, can also affect these areas, causing necrosis and apoptosis. Vasculitis of different kinds. So we know that certain conditions, if you have, say, meningitis, can cause infectious vasculitis of the blood vessels, causing them to thrombose. And indirectly, vasculitis causes ischemia. But we also know that IVH in those zones can eventually, because of the problems of iron accumulation, hemosiderin, free radical injury, also evolve into a situation where periventricular leukomalacia develops. In terms of pathology, really the first description of focal coagulative necrosis in the cerebral periventricular zone was given on autopsy by Banker and LaRoche in 1962. They basically established a timeline of injury which included what we call as a reaction to ischemia, which involved hypoxic ischemic destruction or frank necrosis. And really what happens is that when you have frank necrosis in these areas, then really you have an inflammatory process where, because of ischemia, you have reperfusion injury, free radical injury, and that causes neuronal apoptosis. But the neuronal apoptosis takes time. The acute necrosis happens acutely. And really, in order to mop up and try and clean these areas, you have what we call as macrophage activation and macrophage infiltration into these areas. And that macrophage infiltration, again, is one of the factors that really leads to what we call as cavitation. Eventually, you have healing with the oligodendrocytes basically undergoing a phenomenon called gliosis. And these areas can also get calcified. Now, gliosis is it's a very simple phenomenon. When you cut yourself, you have a scar, and that scar heals by fibrosis. Where in situations like this, when you have injuries, those scars basically heal by the phenomenon of gliosis. And gliosis basically is scarring. And the problem with areas that are scarred, like if you have a periventricular area that's scarred in this particular situation, really this area then becomes an area where future nerve cells that would have determined, omnipotent nerve cells that would have developed and basically proliferated into nerve cells that supply the different organs of the body, are unable to do so. And hence, we're kind of in a situation where you have significant problems later on in life because of these issues. Just moving forwards, we've basically got and classify periventricular leukomalacia into certain types. So we have focal periventricular leukomalacia. Again, if you have kind of lenticulostriate vessels involved, and I'll talk about that, they're very focal. They tend to kind of supply the basal ganglia, but really the deep perforating vessels tend to supply the paraventricular areas. And really, if you have ischemia in those zones and it's localized, then you kind of have a focal periventricular leukomalacia. On the other hand, you might have diffuse cytotoxic injury from an infectious process that basically involves wide areas of the brain. And when this heals, again, what you have is a decrease in content of white matter because of problems of late neuronal destruction or apoptosis. And that basically causes the white matter content to diffusely reduce. And that may be visible as a thin corpus callosum with really a lack of gray-white matter differentiation that's better seen on MRI. But in term babies, it's more the superficial vessels that might be involved because of hypoxia. And really what you see is what we call is subcortical PVL that I'll speak about later on. Now, the classical mechanism of hypoxia ischemia that occurs in preterm babies is very different to hypoxia ischemia that really takes place in a term baby. And that in term babies, what we find is if you have acute hypoxia ischemia, they'll go through a primary and a secondary phase. The primary phase is basically a phase where you have acute cell destruction and necrosis. And really, the secondary phase is one which occurs later on where the nerves after reperfusion tend to be in a state of suspended animation. And then some of those will recover depending on how we resuscitate babies, but some will basically die over time. In this pathophysiology, really, the hypoxia ischemia is one aspect of injury because there is an inflammatory process which is also taking place, which takes much longer. So, like with hypoxia ischemia, where you have symptoms within hours, really what we find is the pathology of this pathophysiology actually takes weeks to develop. And eventually, this oligodendroglial death in numbers sufficient to kind of create cavitation will often develop 2 to 4 weeks later on. The cells will die, but for them to die in enough numbers to produce cavitation that we see on ultrasound really takes weeks to manifest. And it is basically because of ongoing, I would say, inflammatory process. So any preterm baby can have infection, can have fetal inflammatory response because of in utero infection. They might need resuscitation at birth because they've had hypoxia ischemia in utero. And really, all of these eventually, when you have hypoxia, you basically interrupt the sodium potassium ATPase pump. You create an anaerobic environment where cells basically will fail, sodium will have influx. But really, what I'd say is there are other mechanisms at play as well, in that you have reactive oxygen species produced, which eventually result in neuronal death. Depending on pathology, you can have other factors. Like with IVH, like I said, you have increased iron content, and this iron basically acts as an oxidative stress, which again helps in generation of free radicals. Uh, Again, what I'd say is if you have ischemia, you have reperfusion injury, which results in glutamate receptor activation, which reduces your ability to kind of deal with oxidative stress. So what I'd say at this particular point is different pathologies, which include infection, ischemia, possibly problems with in utero infections of a viral nature, like certain torch infections, can, through different mechanisms, eventually give rise to what we call as a pathology. And that pathology can be focal, affecting a certain area of the brain in the periventricular area, or it may affect white matter in a more diffuse way. Now, if it affects it in a more diffuse way, affects it bilaterally, then really what you see is you tend to see a brain that's not growing with wide extraaxial spaces with very thinned out cortical areas of white matter and often a thin corpus callosum. So you kind of have what is called a more diffuse white matter injury. Now, a lot of the pathophysiology depends on the interaction of the different cerebral supplies. Like if you have hypoxia ischemia, you've got the anterior cerebral artery supplying this zone, you've got the middle cerebral artery supplying this zone, and really towards the occipital region, you have the posterior cerebral artery. But really, what we've got is we've got blood vessels which are long penetrators supplying the deeper areas. We have the short penetrators. And this area in between that you see over here in this particular image, and I'm just going to annotate it for you, becomes very vulnerable as a watershed area, this paraventricular area, because there is a compromise between the deep and superficial vessels of the brain. This area basically has the least of its blood supply, and any kind of compromise will make it even worse. Now, naturally, from our perspective, this is just a two-dimensional image. This injury can actually, if you look at prior images, and I'm just going to show you this. Can extend anterior to posterior. So again, this paraventricular area is very vulnerable, and we tend to see blush in this particular area when we see it. If it's very prominent, basically, we worry and we have to follow it up. But you can clearly see that these regions also have the thalamus, have basically the basal ganglia, which comprises the putamen, the globus pallidum, and the internal capsular fibers quite close by. So really, from our perspective, not only are the paraventricular areas quite close, but these areas that cover the fibers that basically supply, in particular, the limbs and the lower limbs. Hence, the kind of manifestations of babies having spastic diplegia of varying degrees once you have injury of this kind, which creates cavitation later on in life. Now, when we talk about PVL and we talk about diffuse white matter injury, really there is a slight difference in the process in that PVL tends to have a predominance of both gliosis and neuronal loss. So you'll have acute necrosis resulting in neuronal loss, which will affect these areas. So if you have PVL, you can see that it's not just the paraventricular areas. Areas like the thalamus, putamen, globus pallidus, hippocampus are also affected to varying degrees. And that's really because the fibers and the nerve cells progressing through this area are really bunched up in a very close space. Uh, they have gliosis to a great degree because of this necrosis, because there's healing that takes place. On the other hand, with diffuse white matter injury, which tends to kind of affect more of the diffuse nature of the outer areas of the brain without having any specificity. Really, the involvement of the thalamus, putamen, globus pallidus, and hippocampus is less. So again, this has implications for future neurodevelopmental impact. Again, you can see that the cerebellum is, is affected in both these regions as well. So saying that PVL is just a disease that affects these ventrolateral aspects is actually a misconception. Uh, in term babies and in babies where the superficial areas get involved, and this is a classical, I would say, anterior cerebral artery kind of distribution involvement, often what you'll find is that the spectrum of disease shifts to the more superficial areas. Now, if these superficial areas are just in the frontal lobe and they heal, then really the chances of the baby having a better neurodevelopmental outcome improve. This kind of, I would say, appearance is not unusually seen in children who might have cardiac disease, term babies. At the end of the day, what is the kind of epidemiology of the illness? Really, what kind of babies tend to be affected? So we know that periventricular leukomalacia tends to be uncommon in term babies. It tends to be common in babies under 32 weeks of gestation, less than 1,500 grams. So the incidence has been quoted to be as high as 38% to 45% in certain studies based on gestation and weight alone. But just remember, not all of this will be severe. And there will be a spectrum of children who might have white matter injury who can actually do quite well later on in life. So we need to be extremely cautious about being too I would say, objective about how we prognosticate babies. I think what I'd say is you really need to have the involvement of a good pediatric neurologist, a neurodevelopmental team who are following these babies up, because the ability of the brain to heal, we know now, with good postnatal care and good interventional therapy, is massive. Neuronal plasticity has a big thing in being able to kind of get these babies to better outcomes. We see this outcome uh, affected quite significantly, especially for children who are brought up with parents who live in with a better socioeconomic status, simply because I think they probably have better ability to be able to provide interventional services for their children. Now, when we look at PVL and white matter injury, just from a numbers perspective, well, assuming you have about babies under 1,500 grams, about 7,000 babies will develop cerebral palsy yearly. and 20,000 to 30,000 will exhibit major cognitive defects. And a significant proportion of these babies will have periventricular leukomalacia under 1,500 grams of weight. In terms of risk factors, what we know is that there's a variety of risk factors. I'm not going to go into the detail of all of them, but the most important aspects of risk factors are any preterm baby who has problems with either hypoxia ischemia, chorioamnionitis in the form of infection, intrauterine infection, is at high risk. And really, from our perspective, how we manage these babies then increases that risk. And a simple example that I'll give you is that if with these babies, you keep them hypocarbic for an extended period of time, so inadvertent hypocarbia, you will cause cranial vasoconstriction and just compound hypoxia ischemia and make things worse. We also know that babies who have this condition are affected by conditions that happen later on. In particular, I would say necrotizing enterocolitis. And I've seen babies who have had necrotizing enterocolitis at 36 weeks of gestation who did not have PVL go on to develop PVL later on, especially if they're extremely sick, have needed multiple inotropes and have had significant problems with hypoxia ischemia. And the problem there is not just hypoxia ischemia, as I'm describing to you in this slide over here. Really, what I would say is there is a significant inflammatory response in the form of cytokines when you have sepsis, when you have conditions like NEC, which basically then contributes to a decrease in your antioxidant defenses, free radical injury, and causes further oligodendroglial death. So, actually, to kind of say that the early period is when you're most predisposed, I think we need to kind of be cautious with that because you can develop late PVL as well. In terms of how we classify it, there's a very nice classification, which is part of articles in your Dropbox, which has been made by Linda DeVries, which basically helps to grade it. And I think this was probably proposed in the early 2000s, but really grade 1 PVL basically is flare. It's prolonged flare. And when we talk about prolonged flare, we know that flare that normally presents with a blush tends to be triangular, symmetrical, geometrical, not very bright. Basically, I would say it's got a kind of a blurred appearance, and really it starts getting lighter by 3 to 7 days to disappear. But any flare that's extremely bright, asymmetrical, that tends from our perspective to have, I would say, an element of bone brightness to it and lasts for more than 7 days is worrying and really needs to be followed up. And really, if you kind of wait and give this 2 weeks and it evolves into small cystic regions, which are basically localized to the frontoparietal regions, then these cystic regions basically help you classify this as grade 2 PVL. If you have extensive involvement, so when we talk about localized images, and I'm going to show you images today, we tend to kind of say they'll be located periventricular, frontoparietal, but not really involve the occipital lesions. So actually a good opportunity there that vision will not be affected. But once you go into grade 3 PVL, really you've got really extensive kind of PVL, which involves not just frontoparietal regions, but the occipital regions as well. And if the whole of the cortex is involved, really you're damaging everything, then you're in a situation where we call this grade 4 PVL. So this is a classical example of grade 1 PVL, and history is very important. So if I kind of said to you at this particular point that this is a baby who had was born at 25 weeks of gestation, who has had cord prolapse and was in a situation where the baby basically needed extensive resuscitation. And you kind of did a scan like this on day 3 as part of your routine screening scan and saw this kind of brightness. Can you see how it doesn't really have any geometrical kind of pattern? It's not very triangular. Some of the areas actually look bone bright in this. It's very asymmetrical. And in particular, if it's asymmetrical on both sides, when you see the coronal views, which I will show you, then that really does need follow-up. Now, the expectation for normal blush is that it won't be as bright as this. And really, by the time you repeat your scan in 7 days, it should have disappeared completely. But a good proportion of, I would say, injuries like this, which are mild and may present with flare that we might think is pathological, can actually improve within 7 days as well. So it's just an awareness that you could still have mild hypoxia ischemia, which can give you flare that can improve with time. On the other hand, as I said, and this is a coronal trigonal view, if you start seeing basically small cystic regions, and really this is the parietal area, This is the frontal area. Now, what you can classically see at this particular point, and this baby is a few weeks old, is not only do you see these small cysts with degeneration in the frontoparietal areas, you can see them in the periventricular areas. Again, small cysts. So I'm just going to annotate so that you guys can see. So this area here, you can see this area here. But what is also important is look at the extraaxial spaces. I mean, they're quite wide. You have a wide interhemispheric fissure. So the brain's not really growing as much. And in general, the kind of blush that you'd see in the periventricular areas, it's not really there. So again, you're slightly worried that the kind of differentiation that you'd see between white matter blush is not there. So the question is your white matter developing appropriately? This is just, again, the sagittal section, which basically shows a focal area. Now, a classical kind of presentation could be a baby who's been born in utero with significant chorioamnionitis who, say, develops E. coli septicemia and has a significant toxemic response, who needs inotropes, who we ventilate, intubate. Again, hypocarbia causes significant injury here. This is basically the watershed area of the middle cerebral artery. So if you have cranial ischemia, you can have presentations with kind of cystic change like this. And again, that's one reason why we should be quite aggressive in trying to keep these babies normocarbic as far as possible. You go to the next stage and things have become really bad. So not only is this frontoparietal, really what you've got at this particular point is spread to the occipital region as well, and there's quite extensive kind of periventricular involvement. This is basically a sagittal section. Now the question is whether you've got clot over here. So you've had an IVH previously with ventricular dilatation. You can see that the ventricular margin is quite irregular. It's been destroyed, most probably by an infiltratory process, which really involves a reaction to iron deposition within the clot. Uh, this gets converted into hemosiderin, there's free radical injury, and really the paraventricular area, which was surrounding this clot, has basically now started becoming moth-eaten. And this moth-eaten appearance is quite extensive. It's frontal, parietal, and occipital. And really the prognosis here becomes quite worrying. If it's bilateral, I mean, this kid is not just at risk of having the possibility of a spastic diplegia, involvement of hands and legs, but actually there's also a risk that vision might be affected. And sometimes you've got what we call is the sieve-like appearance of the brain. So actually the whole of the brain in this particular image, the trigonal view in the coronal sections really is completely moth-eaten. And I mean, to be fair, I've seen this about 3 or 4 times in my career where the whole brain is affected. And it's really quite interesting. Of the 3 of the 4 cases that I saw, all 3 babies had been extubated, were breathing, and really a kind of a comfort care approach was quite difficult in those situations because these were babies who had extensive brain injury with quite significant parenchymal involvement. And actually, follow up for 2 of those babies was really, it was quite devastating in that they both ended up with quite significant spastic involvement of all 4 limbs. So hearing problems again would be a worry here. Occipital involvement means might have visual problems as well. Now, I'm just curious. So let's open this up now to all of you. So we've got 19 of you here. What do we think about this image? So I'm going to basically ask, uh, I'm going to ask Dr. Dr. Amani, are you able to talk to us today?
Yes, yeah, I am. Can you hear me?
I can. So if I were to give you a history over here,
Right.
and say that this is a preterm baby delivered at 26 weeks. The baby basically has problems with antenatal rupture of membranes, which took place when the baby was about 19 weeks of gestation. So the mother was not treated with antibiotics until a week back. The baby basically, mother went into spontaneous preterm labor. The baby had steroids, was delivered, and basically needed resuscitation with intubation, ventilation, had a poor heart rate. So was given compressions at a kilo, recovered without a dose of adrenaline. And really, this is a scan that you see in this intubated, ventilated baby at 3 days. So what do you think about it?
Right. So this is a sagittal view. Is this the left or the right?
So you can assume it's the left. It's not very
Okay.
clear, but it's the left. Yeah.
Right. So I see that there is the ventricle. It's not dilated. It looks like it's the normal size,
Yeah.
but periventricular area, it all looks white, like a flare or a hypoxic insult. Because you can see that it's widespread in all areas.
Yeah.
Um, Actually, it's quite extensive in every, like, periventricular,
Yeah.
frontal, occipital.
Yeah.
Uh,
Absolutely.
yeah. I'm not sure is in the frontal area I can see small cyst, but I think it's the more obvious is the flare, the white area,
Yeah.
very echogenic.
Yeah. You're absolutely right. And this is basically an old machine, like an old Fujitsu, which from our perspective is using a very narrow window and basically covering a very, I would say, broad area. But the most important reason for wanting to show you this is, what do you think about the gain settings?
It's quite high gain. I mean, you can't differentiate white and gray areas.
Yep,
So I think yes, and you can actually see it as bright as the bone.
yep.
Yeah.
And I would just caution everybody that I personally agree with this. I mean, this is basically a picture taken from a journal article. And I think given the history, when you clinically interpret this image, I would be very cautious. I would be a little bit cautious about this in the settings of the gain settings I'm using because that will tend to exaggerate gain. So just always remember, just be very cautious that your gain settings are optimized for this. The second aspect that I want to kind of clarify is really you have missed out the whole of the back of the brain here. And really, what you need to be able to do in this situation is be able to see flare in its entirety. Now, if it gives you a kind of geometrical appearance, it's not very bright, it's symmetrical on both sides, it disappears within 72 hours to a week, then really, from our perspective, that could just be normal blush. But just be very careful that if with normal gain settings, it looks like this, and it is not geometrical, it's basically everywhere. Now, there are two possibilities here. If the gain settings are normal, really from our perspective, there is a worry that this reflects quite a diffuse area. Now, what do we think in terms of etiology here, Dr. Mani? What do we think the etiology might be?
It's probably antenatal infection
Very good. So,
causing inflammation. Yes.
yep,
Yeah.
yep. So, chronic inflammatory response. So, this injury is antenatal. And to have this appearance, really, from our perspective, antenatally, if this injury has happened much earlier, cyst formation for this particular region might occur quite quickly. You might find that when you actually repeat your scans, which you'd probably likely do weekly at this situation, is you start seeing cysts within 2 weeks. The key giveaway is there's no significant IVH here. The other giveaway is it's very bright and it's very diffusely bright. So again, the possibility that there's an infectious process going on over here with that history is quite high. So again, I mean, it's just important that we always clinically contextualize, that we say things in clinical context. Because if I told you this is a 33-week scan for a baby who's had no resuscitation, who's kind of in a situation where he's lovely, pink, well perfused without any significant problems, and your gain settings are high, you can easily misinterpret things. So just be very cautious. Always interpret things within light. So, Dr. Kunal, Dr. Kunal, can you hear me?
Yes, I can.
What do
I
we
can hear
think?
you.
What do we think over here?
This is again the sagittal view.
Okay, do you want anything
Uh,
from me? Clinical
Sorry.
correlation?
Yeah, history.
Okay, very important. So again, this is a baby who had basically quite significant trauma. So Anne had rhamnios, and the baby basically was delivered at 24 weeks of gestation, didn't need resuscitation, but basically has been cultured positive for E. coli septicemia. And with that E. coli septicemia, has had uh, positive CSF and basically has been treated with 3 weeks of antibiotics. And this is a scan. So early scans showed significant flare as bright as this. And really, this is a scan that's being done after 4 weeks. So how would you describe this?
The the in the particular image, the ventricle is looking little dilated.
Very good.
Then the periventricular area in the occipital, in the posterior region,
Yeah,
it has already starting some cystic areas have started to appear.
yeah. So when
No,
you make that interpretation, this is a scan that's been done at 4 weeks. What else would you look at if you didn't know this baby and you were scanning this baby for the first time? What kind of steps would you go through?
at 4 weeks.
Yep.
We would first like to know what was the first week scan. Was
Beautiful.
there any flare or anything noticed in the first week
S-
scan
So
and
there was flare, and actually the scans done on day 3 showed significant IVH. There was grade 3 IVH
okay.
bilaterally.
Okay. So yeah, grade 3 IVH over the weeks can progress into periventricular leukomalacia as the weeks progress.
Sure.
So that's the possibility.
And in terms of the kind of distribution, so can I ask, what do you
Yes,
think is
please.
this?
That's the area of thalamus.
Okay.
Yeah, that's the
And what does it look
there.
like?
It looks like honeycomb appearance, probably.
It's very bright.
There,
It's
right,
in
yeah.
some areas that are bone bright. So, I mean, not only has this kid got periventricular leukomalacia, he's got lots of brightness in the area of the thalamus bilaterally.
Mm, yes.
So again, possible hypoxia ischemia,
Okay.
again, infection causing trauma. He also had
Mm,
IVH, whether there's an
mm,
element of clot that we can't see, but the choroids actually look bone bright as well. It's a very irregular choroid. So in
okay.
particular over here, very irregular choroid. So I think this is multifactorial, but what is the distribution? So when you classify, so when we classify it, is this focal or diffuse?
No, it when we classify this, because it's multifactorial and asymmetrical, we can say it as diffuse. We can call it as diffuse because it's involving both periventricular and thalamic region.
Yeah. So
And
again, the question that I would always emphasize to you is we never make that diagnosis in one view, we confirm in two views. So I
okay,
would basically have to give you the coronal views for you to look at the periventricular areas to kind of make that diagnosis. So
okay,
just, yeah, I mean, from our perspective, yep, it looks pretty bad at the moment, but really the parietal area and the frontal areas might be spared. And
okay,
again, just image quality. We've cut out virtually 50% of the brain. We don't know what's happening at the back at all. So again, it'll be little difficult for us to kind of classify this, but what we know is the kind of parietal area posteriorly and the occipital area involved. And that makes prognosis bad. If parietal and occipital areas get involved, frontal areas really kind of being spared, you would still call this grade 3 PVL. Do you get
okay,
that? Yeah. Once the
yeah,
occipital areas, and usually occipital areas involved with parietal areas, it becomes grade 3 PVL. And really vision becomes a slight worry. So this is just evolution of PVL over 3 weeks. So Maria, would you like to talk to us about this?
Yeah. So there are 3 different weeks.
Yeah, so that's week 1. So I'll just
Yeah.
annotate for you so that it's easier for you to talk through. This is week 1. Okay. This
Yeah.
is basically 2 weeks. And this is basically the 3rd week.
Okay. What is the history of this baby?
I'll have to make it up, to be quite honest.
Okay.
Uh, but you can assume he's had an element of hypoxia.
Okay. It's a term baby.
No, he's not a term baby. He's a preterm baby. He's 25 weeks. And these are screening ultrasounds over 3 weeks.
Okay. So I would say, so I only have a one view for each week, so I'm just gonna
Yep,
assume things that maybe we cannot be 100% sure about.
yep,
I would say that the settings seem much better than the previous images, so the gain looks good looking at the bone structures.
brilliant.
So in the first week, there is an increased brightness, which is very patchy in those two places bilaterally. The extra spaces are increased a little bit,
Yep,
and it seems like even if it's not the perfect view that the uh, ventricles are enlarged, at least at the right side. We
yep,
can't be really sure on the other side. Then after 1 week, I would say that uh, it looks like sort of a, I don't know if it's a correct word, but the brain atrophy progressed
yep,
because yeah, the spaces are even bigger, and the brightness evolved into cysts in the frontal, and yeah, in the frontal brain, and maybe parietal as well.
yep,
And the ventricles are definitely enlarged.
yep,
Um, and then um, on the third week, we have, yeah, on both frontal, parietal, and I would say the occipital brain from the sagittal scan is also starting to cavitate
yep.
a little bit, and the brain atrophy is even more evident.
So if you had to grade this, like let's say we're grading C and D.
Yeah, it would be a grade 3.
Yeah, I agree. And what is really important from your perspective is I I want you to move away from grades because for prognostication, really it's really important to be able to understand whether it's purely frontal, which is very rare. Often when you have PVL, it is frontoparietal. Uh, if it's frontoparietal and occipital, that's a really worrying spectrum. And if it's bad enough for it to involve euthalami as well, as you saw in the previous images, then that's quite extensive involvement, as you might see with hypoxia ischemia. Uh, Again, what I mean in terms of prognosis, let's say this was a scan that was done at 36 weeks. Okay, let's leave prognosis for the time being because we're going to do that in the workshop towards the end of the course. It's much better. We'll have role play and it'll be much better. Uh, Again, just these areas of focal ischemia, very bright. They look ischemic, but again, really, when you look at the kind of evolution, it's just interesting how areas that look less bright are actually more broken down than these areas that looked bone bright at that particular point. So again, the inflammatory process and how it progresses may not necessarily correlate to the brightest areas breaking down to the maximum extent. And really, it's really important that we continue to follow up and we try to classify this and try and classify it based on not just the grade, but actually look at the areas of the brain that are predominantly affected. By the end of the kind of third week, you can really see here it's frontoparietal, but here really frontoparietal, and you're really worried that it's spreading into the occipital region, as you've rightly pointed out. So I think what I would say is you never prognosticate parents based on early scans. And a lot of centers really would eventually get MRIs done where it's possible, like Linda DeVries Center. They would sit with a pediatric neurologist, talk very cautiously about how these babies might do in the future. What is your scanning protocol, Maria, for these babies at the moment? Like, when do you do your last scan?
So there is no real scanning protocol. I was actually hoping to implement it a little bit. What I'm used to do for preterm infants, I will go up to term, so 36, then term, and most of them, because of the school that I'm into, they would get the MRI done
At
at
44
term.
weeks? Or,
After term, yeah.
yeah, it's quite interesting. You want to leave it as late as possible for the MRI because naturally its pickup and kind of white matter injury will be much better the later you leave it. And then the question is, they often get discharged from the neonatal unit. So follow-up and prognostication, and even talking about these babies, I find it a very difficult area because really plasticity is a major component of healing. And really, I've seen quite variable outcomes for babies who kind of have grade 2 PVL. And that's, if it's just frontal or parietal, these babies can do very well and can be cognitively normal.
I have a question.
Yeah.
I'm not sure if we're going to talk about it later on, but let's say that this baby was intubated and ventilated, and the parents would ask for termination of care. Would it be something
I
considered
think just with
reasonable?
this appearance alone, if I'm kind of, see, these are scans over 1, 2, 3, and 4 weeks. Uh, I think we have to be very careful within the first or second week. We really want to make sure that we've established that this is PVL of the kind that we see over here. I think if you kind of had this kind of an appearance where the whole brain is like a sieve, uh, then I think I would look at the clinical course, everything together. But I would be supportive in situations like this. I think whilst you're over here, a lot of this depends on neuronal plasticity. Now, if you have quite extensive frontal, parietal, and occipital involvement and it's bilateral, then the chances of plasticity playing a role at this particular point become a little bit more difficult because both sides of the brain are abnormal. I think what I would be doing is, again, it's a very tricky one for us. In the UAE, it's really what the parents would want and their choice. But in terms of kind of extubation, we can't legally extubate for the baby to die. So theoretically, it becomes more difficult for us. But in the UK, I think if you had bilateral grade 3 involvement quite late on, then I think there would be a cohort of clinicians who would be supportive of that. I think much earlier involvement, stuff like this, just be very careful. Because, like I said, even here, if this is unilateral, if it's only frontal and just parietal, again, I would be very cautious. I would be very anxious about being definitive with the parents that your baby is going to have a very poor outcome. Because really, if you're just basing this on the outcome of the baby, we know that cranial ultrasound scans alone are the actual predictive accuracy of a cranial ultrasound done at one point of time, say 3 weeks of age, for an appearance like this, may not accurately predict the long-term outcome for this baby. And I think parents need to understand that whilst we're making these decisions. But towards the end of the course, we are going to have people, experts who are involved in counseling ourselves, uh, pediatric neurologists who will basically be able to talk us through this. The only
Thank
thing is we will put you on the spot. So, and those aren't going to be recorded sessions, please. So the idea is to give you complete freedom to be able to think, about how you would prognosticate for your setup and really then kind of talk about what the expert thinks. And really, the reason why that's a beautiful exercise for us to go through is, see, when I talk about the ethics of the situation, so we've just finished a study over here in the UAE that I'm basically doing data analysis for, which is called the Evaluate study. Now, we're talking about the baby here, and we're talking about parental choice. But there are a large number of factors in other countries. Like if you go to India, and people can't even afford to eat, and they sell their whole land because they want to keep a baby like this alive, and they ask for stopping life-sustaining intensive care. I think we'd be talking a completely different kettle of fish in terms of stopping care versus a situation where we can't legally extubate without an absolute certainty of prognosis, which is how we practice in the UAE. So it's quite tricky. But what we aim to do is by the end of the course, when we talk about all of these things, we talk about HIE, we talk about PVL, we talk about IVHs, give you a framework that is generic, that is an approach that all of us would take in terms of how we approach the situation. But in terms of what we say, a lot of it would depend on our country, the kind of ethical practices that we practice locally. Uh, Again, what I'd say is that in the UAE, pain is not a major factor for withdrawal of care, but suffering and pain are a major factor for kind of considering stopping life-sustaining intensive care in the UK. So there will be differences in practice and differences in approaches, which I believe should not be judged. And I'm taking a little bit of time here, in that because we may not practice the same way, and a baby may end up with slightly different outcomes based on the local practices, expectation of the parents. I think we should be very careful about making judgments of those systems. So I've given you a very confusing answer to a very difficult question.
No,
I'm
thank
just,
you.
yeah, and again, what what is better is for us to present real cases, and going forwards, that's what we will be doing. So I will be presenting cases like this and how we manage them and the approach. Can I just say that there are babies like this who breathe? There are babies like this who breathe. So this scan that you see on the right side, like I said, two of my four cases like this, we extubated and they were breathing. They did not die. And the approach of limiting nutrition was discussed, but that's for another day. It's something that not a lot of people would be very comfortable with. So we'll discuss it. Any other questions so far? Okay.
All good.
Yeah.
May
Okay.
I have a question?
Yeah, please.
Okay. If a baby have BVL, even if grade 4, it will not affect the breathing because the breathing center in the brainstem.
That's the point I'm making, that it may not be affected. I think what we've got to kind of realize is that if you have extensive brain destruction, then the cortical centers which control breathing may be affected, but there might be other pathology that's going on. So if the baby's intubated, ventilated, and is septic, and he's not breathing because of that, you know, he's on triple inotropes, we're on maximal doses of adrenaline, and his brain is shot to pieces, then, and hence I'm saying that when we talk about stopping life-sustaining intensive care, it's never based on an image alone. It's based on the overall condition of the baby. And then there are those babies where we go in with plans where we expect them to die and they don't die, they breathe. And that's why parallel planning is a very important aspect over here. So do you know what parallel planning is? Anybody?
Having a different plan from the original one. Say, for example, if you plan to stop intensive care and the baby breathes, then you should have another plan of how you would manage the baby.
It's not just having a different plan. For me, parallel planning is about having the parents understand that actually we may be planning for stopping life sustaining intensive care. We may take the tube out, but this baby might actually breathe. Now, if he breathes, then really what we've got to do is we've got to meet his basic needs. We've got to then think about his future as a baby who's breathing, who still has this kind of brain injury that you can see on the right over here. I mean, this is quite extensive PVL, which basically involves the whole of the occipital region. Again, it's one image, but my real worry over here would be the risk of, it's the parietal cortex extending towards the occipital area. It's quite extensive bilateral. The chances of neuronal plasticity are low. Now, if we decided that we're going to kind of extubate this baby and he breathes, then supporting palliative care in this situation might mean telling the parents that, look, he's breathing, but what we're going to do is if he deteriorates with another condition, we might not reintubate him again, and that being acceptable to the parents. So that's parallel planning. And you should have had this discussion prior, because what you don't want is the parents to be completely shocked. Oh, you never told us the baby was going to live. We expected you to take the tube out and the baby would die. And it comes as an incredible shock to them when suddenly the baby's breathing and they have to think about an alternative kind of outcome for the baby. Because some of these babies, and at least, like I said, there are babies who I've seen with quite extensive injury to the brain who've gone on to survive. And really, it can be quite distressing for the parents in those circumstances. Uh, just going forwards. So just a little bit about prognosis. So like I said, with all preterm babies, having a triangular flare in the first week of life is quite common. But once this is more diffuse, and this is a classical example, this flare has no geometry to it. It's quite diffuse. It's not geometrical. It's asymmetrical. It's larger on one side as compared to the other. There are regions that are virtually bone bright in this area. So this is really worrying flare if this is something that you see. On the other hand, what I'd say is that if flare is a little bit less bright, like this, maybe a little bit less bright, geometrical, and this disappears by the first week of life, then really this is just flare. It's blush. So really, from our perspective, be very careful about deciding that a baby's got PVL in the first week of life, no matter how dense that flare looks. Worry about it, follow it up, but by all means, please be very careful of saying this is PVL and your baby is going to have a poor prognosis. It is really interesting that even with transient echo densities that disappear within the first week of life, uh, the prognosis is equivalent to normal cranial ultrasound findings, and that means that you have a less than 5% risk of neurodisability. So if you have normal cranial ultrasounds in babies over 26 weeks of gestation at term, and this was a normal cranial ultrasound throughout, the risk of that baby having neurodisability is less than 5%. I think this is work that's been done by John Wyatt and his group in UCL, but I think below that, this does not hold true. So 23 to 25 weeks, 22 weeks, we need longer term studies to kind of prove that. If you have extensive cortical echolucency, again, basically a lack of kind of differentiation of white from gray, then that is really a marker of CP. And that tends to kind of be picked up more by MRI. So if you kind of are in a situation where you tend to have cortical echolucency, here you can classically see this blush, this differentiation. But if there's no blush and there's just a diffuse echogenicity that looks less echoic or hypoechoic, then really that is worrying because that indicates that your white matter is deficient. It's seen more in kind of diffuse white matter injury as opposed to kind of PVL alone. Now, if you have cystic echodensities that occupy the frontotemporal parietal regions, they are strongly related with motor CP. And they may also involve auditory and visuomotor problems later on in life. So, I mean, it's invariable that I think the description is that 75% of those babies are affected. On the other hand, if they're non-cystic echodensities, so very much I would say like this, and they persist from a period of 2 weeks, then really the risk of CP is about 50%. So by 2 weeks, if they've completely disappeared, then really there's a chance that 50% of these babies can be completely normal. So I think my take home message when you're doing and talking about PVL is you really need to follow them up. You need to do serial scanning. You never prognosticate on a single scan. You wait till term. And really, what I would say is it's really important, even with clinical pictures like this, that you always give parents hope. I think telling parents that your child has cystic PVL, because they'll go on Google and read it. And when they read it, it talks about holes in the brain with a very high risk of cerebral palsy, being in a wheelchair. I think I'd be a little bit cautious of that interpretation of PVL in isolation, because really, if it's limited to the frontal regions and it stays like this and actually gets better with time, and you just have extraaxial space with thinned out white matter and a thin corpus callosum at the end of this, then the prognosis is going to be very different to the baby who's got fronto-parietal occipital involvement with extensive cystic breakdown. The challenge for us is we can never be certain about how severe, because neuronal plasticity means with good neurodevelopmental care, we are improving the potential of this child. I think if you have something like this, this is really bad. And my experience of seeing this again is you may see survivors, but all of them have bad cerebral palsy. At least that's my experience. So again, if you have something like this, I think doing an MRI, if this is what you can see at 44 weeks in a scan, is not really going to, it may add to kind of a few things with the experts, but I don't think this baby is going to have a good outcome. The question is how bad. And whether an MRI can give you that information accurately. It'll be an interesting talk by one of our pediatric neurologists towards the end of this course to kind of tell us about that. So again, just examples of grade 1, grade 2 IVH. This is cystic PVL for you. These are coronal and transverse images. And can you see the association with increased extraaxial space that you see? Now, this is frontal, which is really bad, parietal, which is quite cystic, and then cyst formation in the occipital area. So again, this is really bad cystic grade 4 PVL. So any questions? We will have a whole session of prognosis. We'll be doing HIE separately. We'll be doing PVL separately. And the intention from our perspective is we'll give you cases, we'll give you real cases where we have anonymized the scans of the babies so that we can protect their identity. We already know their outcome. So the intention from our perspective is you will see those serial scans. We'll talk about what you think about them in a unrecorded video so that it's a very safe environment. And the intention from our perspective is for you to give us an accurate kind of a approach to how you would follow these up and what you think happened to the baby, and then we'll tell you what happened to the baby. But what I would strongly encourage you to do, you've got 4 days before the next talk, is in the article library. There is a really nice article library on IVH and PVL, and I would strongly recommend that you read the articles on prognosis, because making a diagnosis will not be difficult, but prognostication can be quite difficult, and there's some very nice articles there. Any questions? Thank you, everyone. Today was short and sweet. We will see you on Sunday again when we will talk about post-hemorrhagic ventricular dilatation, which basically is a follow-up to one of the sequelae of IVH. We'll be talking about not just imaging, but also management. So have a good evening. God bless you all.
Bye. Thank you.
Thank you.
Thank you.
Thank you.